Hi, good evening, everyone. I'm Dr. Apurva Gupta, gynecologist practicing in South Delhi. On behalf of my clinic, which is the Gynaecologist Women's Clinic, I welcome you all to another session of Facebook Live. And this one today is going to be on heavy periods. Okay. Now, this is, trust me, coming by popular demand because a lot of my friends also requested that I should do a session on heavy periods. So here I am back to you. So before we discuss what do we mean by heavy periods, I think we should first understand what are normal periods, right? So what is a normal period cycle? A normal period cycle is something which occurs anywhere between 21 to 35 days, and the bleeding can last anywhere from 2 days to 7 days. Okay, so this is what a normal period is. And if you ask me how much should be a blood loss during normal period, we can quantify it anywhere to say 25 to about maximum 80 ml blood loss. Okay, this is a definition of normal period. A normal period normally wouldn't have clots. A woman wouldn't normally pass clots in a normal period because what is said is once the period is generated, clots which are generated are actually lysed or dissolved by the enzymes inside the body, and so when the patient passes period, they are normally, then there are no clots in it. So if there are clots in a menstrual blood that a woman is passing, that means that the bleeding has been so heavy that the body hasn't got time to dissolve those clots. That itself qualifies as a heavy bleeding. Okay. So this is roughly what you expect a normal period to be. So what is a heavy period, or what is abnormal or heavy bleeding during periods? Okay, so I would say roughly this can be of 3 types. Okay, one is heavy bleeding during the period itself. That means the period is coming regularly as it normally does to the woman. Suppose a cycle is 28 days, so she's getting it every 28 days. And it's lasting maybe for like 3 days, 4 days, but normal cycle, but the quantity of bleeding is more. Okay, so this is one type. This normally occurs when there is some problem in the uterus of the woman, right? So there could be some polyps. So the target organ, which is our uterus, is having some problem, as a result of which the bleeding is heavy. The second type is the cycles are short. That means instead of every 28 days, now she's bleeding, say, every 15 days or every 20 days. So automatically it's leading to more periods and heavy periods. The third type is when there is no fixed pattern. Okay, so she is bleeding early and she is bleeding heavy, and it may also be irregular. So that is obviously, in the second type, the problem is likely to be with the hormonal axis of the body, and the third type could have a relatively more severe problem. Okay. So primarily first we will be discussing, and today's topic more so will be focused on the first type, cyclical bleeding but heavy bleeding. Okay, so this is one of the most common complaints. What can be the causes of a woman having heavy periods? Okay, so first could be anatomical causes. She could have fibroids inside her uterus, nothing but aggregations of the muscle of the uterus. There could be some polyps, like the little massa. So there could be some polyps the woman could have. Okay, these could be the anatomical problems. There could be some hormonal problems. Okay, have a thyroid problem, her prolactin could be raised, or the hypothalamo-pituitary ovarian axis is disturbed in some or the other form. Okay, so this is another cause of heavy bleeding. Then there are certain other causes like she's got a copper T or an IUCD which has got displaced. There are some malignancies. There are bleedings which a woman is taking pills and then she's not taking it regularly, or she leaves. There is endometrial hyperplasia, which is thickness of the lining of the uterus. Then there are some pelvic infections. So all these things can also cause heavy. First, I shall be discussing the most important and the commonest cause, which is fibroid uterus. So, fibroid uterus are nothing but benign tumors. So, they are like normal growths of which come from the smooth muscle of the uterus. Okay, so the muscle gets into a forms lumps which are called fibroids. Okay, now fibroids most of the times are incidental findings. Most of the times, fibroid won't even give any symptoms. A woman just goes for an ultrasound for some other reason, and coincidentally, we may find fibroids. Okay, sometimes fibroids may be symptomatic though. Okay? So, fibroids are of three types. So basically, we have the uterus and we have the wall of the uterus. So depending on where the fibroid is located, we classify it into three types. The first type of fibroid is which is outside the uterus. The second type of fibroid is which is inside the wall of the uterus. And the third type of the fibroid is it arises from the wall of the uterus, but it indents into the cavity of the uterus. So obviously, if a fibroid is indenting into the cavity of the uterus, then it is disturbing that layer of the uterus which bleeds during periods. Also, it is increasing the surface area of that layer which bleeds during periods, as a result of which these fibroids which indent into the cavity of the uterus are most likely to cause period-related problems or heavy bleeding in short. Fibroids which are outside the uterus normally are asymptomatic. They do not cause any problem to the patients unless the size is so big that it is causing some pressure effect or feeling of lump in the body, vague pain. Fibroids which are within the wall of the uterus again normally do not cause any trouble unless the size is so big that it is causing pressure effects, or it is causing feeling of lump, or it's pressing on the bladder or the bowel or giving some pressure symptoms to the patients. Rarely these fibroids, when they grow too big, then they indent into the cavity of the uterus, right? So once the fibroid begins to indent in the uterine cavity, then it begins to give number one symptom, which is the heavy bleeding. Okay, normally this bleeding is cyclical, but a woman who's having say a 28-day cycle and she bleeds for 5 days suddenly starts complaining, doctor, I am bleeding for about 5 to 7 days. The bleeding is much heavier. I'm passing clots, though it's cyclical. So this is the first thing. Now, first we have to understand one thing. Not all fibroids need to be treated. Okay. So, which is the fibroid which needs to be treated? One, the significant symptoms to the patient. The symptoms could be heavy bleeding. The symptoms could be a big size of the fibroid has become so big that it's causing some pressure symptoms or feeling of lump, or one could suspect some cancerous change in the fibroid, which is very, very rare to happen. Okay, or it's causing symptoms which can be life-threatening to the patient, like the patient is bleeding so much because of the fibroid that she's developing significant anemia. Her hemoglobin is dropping 7, 5 each cycle. So then these are life-threatening situations which a fibroid is creating for her. Okay, or sometimes a fibroid may not create a life-threatening situation for you, but it may create a huge nuisance value. As in, you may be bleeding heavily and you may be wouldn't want to tolerate such heavy bleedings each cycle. So if the existence of the disease is disturbing your normal routine life to an extent that it is value for you, or the patient doesn't want to take it, then also it's an indication to treat the fibroid. So let's see how heavy bleeding due to fibroids can be treated. Okay, obviously your doctor is going to give you first some medicines which are known to stop bleeding. We call them hemostatic drugs. So first thing you will get is medicines to stop the bleeding, so that very cycle you do not bleed too much. Many a times patients who don't have very significant symptoms can take these medicines every cycle and they can be sorted. Also, how it has to be treated depends on the age you have manifested the symptoms. Are you close to menopause? Are you in your reproductive years? Is the fibroid also causing infertility issues to you? So all these things have to be assessed, and each case has to be individualized before deciding on the treatment. So the first treatment is a medical management in which we give you some drugs to reduce the bleeding. Sometimes we may also resort to hormonal drugs to reduce the bleeding of fibroids. Next is the surgical management of fibroids. Now here there are two types of surgical managements in fibroid. One is just the removal of the fibroid, and next is the removal of the entire uterus. Now which surgery would you need to opt for, if at all? Then depends on, as I said, we have to individualize each case. What is your age? How many fibroids do you have? Because obviously simply fibroid removals are normally suited for young patients, patients who want to retain their reproductive functions, for patients who have limited number of fibroids. So these are the cases where we would recommend plain fibroid removal. Okay, so a plain fibroid removal, which we call as myomectomy, can be done either hysteroscopically. That means we insert a hysteroscope inside the uterus and we chop off pieces of the fibroid. This normally helps if the fibroid has it's indenting into the cavity of the uterus, right? So we put in an instrument inside the uterus and we shave off that portion. This is hysteroscopic myomectomy. The other or more common form of myomectomy is a laparoscopic myomectomy, in which we put in camera inside the abdomen of the uterus, in the abdomen of the patient, and laparoscopically we see where are the fibroids and we operate and remove the fibroid and suture the uterus back. Okay, so this is laparoscopic myomectomy. The third type of myomectomy is open myomectomy, in which we open the abdomen like you have a cesarean scar mostly. So we open the abdomen through that scar, and then we, like a normal surgery, we remove the fibroids. So anytime you opt for a fibroid surgery, your doctor is going to explain to you risks of fibroid surgery, which are now with advanced medical science more theoretical, but still you never know. Fibroids can bleed a lot during surgery, as a result of which you may need blood transfusions. Rarely a myomectomy may need to get converted into a hysterectomy or a uterus removal by virtue of bleeding. But normally in current day circumstances, we have such, our medical sciences advanced so much that normally we don't land up in such a situation, right? The last resort to treatment of fibroids is now hysterectomy or removal of the uterus. Okay. Now, if it advises you a hysterectomy for fibroids, then normally the patient would be an older patient with multiple fibroids, severe symptoms, and not likely to respond to medical therapy. A patient who is not interested anymore in preserving her reproductive function. So hysterectomy or uterus removal again can be done by three routes. One is the open hysterectomy, in which again we open the abdomen like that of a cesarean scar and remove the uterus. The next is a laparoscopic hysterectomy, in which we, through multiple holes, 3 or 4 holes in the abdomen, we typically remove the uterus. And the third is the vaginal hysterectomy, in which it's nearly scarless because we remove the uterus through the vagina. Okay, so these are the 3 methods of removing the uterus. The other thing is we also have a recent advance in treatment of fibroids, which is called uterine artery embolization. So what we do in this is, the uterine artery is the artery which supplies blood to the uterus. So we put in a chemical substance in this artery radiologically, and we embolize this. So what happens is the blood supply to the fibroid is cut off, and with time the fibroid begins to shrink. Is a recent therapy which has come in for fibroids and is gaining a lot of success. But again, every patient is not eligible for this. We have to tailor make. We have to tailor make and individualize which patient would benefit from this therapy. There are also certain drugs coming up now which say that, which claim to reduce the size of the fibroids. They are not the mainstay of treatments of fibroids. Shrinking them medically is not the mainstay of treatment, but yes, it's gaining momentum now, and we are trying it on more and more patients, that if we can medically try to shrink the fibroids. But if you're in your reproductive years, then normally the fibroids do not shrink by themselves because they are hormone dependent. Fibroids would begin to shrink after a woman attains menopause. So after that, they begin to shrink. What could be the effect of pregnancy on fibroids? Now, pregnancy is also a high hormone state. So normally fibroids either would remain increase in size during pregnancy, but because the uterus stretches itself and becomes so big during pregnancy, the fibroid also stretches and changes shape. So unless it's very, very big, it normally doesn't cause a problem in your pregnancy. if it's very big, then it can cause size-related problems to the baby. Or if it is the fibroid is placed in your birthing passage or the lower uterus, where it can obstruct normal delivery, then maybe a fibroid can cause a problem in your delivery, and maybe that could be a reason for you to have a cesarean. But sometimes fibroid, if it's indenting the cavity, can also cause, I would say, a chance of preterm labor. So this is what I have covered mostly about fibroids. And if a woman is having menorrhagia, an important cause to rule out would be a fibroid uterus. Another cause is what we call as adenomyosis, in which there are lakes, I would say, lakes of the uterine lining within the uterine muscle, as a result of which the size of the uterus becomes bigger and the uterine muscle mass increases, and patient often presents with heavy bleeding. Normally, this can be taken care of medically by hemostatic drugs or maybe hormones also. Sometimes a patient may need hysterectomy for this condition. Let's also discuss one more condition which can cause heavy bleeding to patients. Okay. Now, polyps. What are polyps? Polyps are mini growths which come from within the uterine lining. Okay. So, depending on whether they are placed on the uterine cavity or they are placed on the mouth of the cervix, they would have different symptoms. So obviously a polyp which is within the uterine cavity arising from the endometrium is likely to give heavy bleeding to patients. Okay, but normally it's not just cyclical heavy bleeding. With a polyp would normally present with also intermenstrual bleeding or premenstrual bleeding. That means bleeding also in between your menstrual cycles. So the treatment, the diagnosis of polyp is mainly by a good ultrasound, and the treatment of polyp, the mainstay of treatment is a hysteroscopic polyp. Very good results. So we put in a camera through the uterus, through the vagina into the uterus. We visualize and see the polyp with our own eyes and just scratch it or remove it out. So hysteroscopic polypectomy is a mainstay of treatment and it gives excellent results. So if you have polyp as your diagnosis due to heavy bleeding, I think you just need to celebrate, because it's very, very crisp to treat that. Okay. There are some other causes of heavy bleeding. So let's now come to the other causes. Now, as I said, these are mostly the anatomical causes which I have discussed. There are some hormonal causes which can cause, I would say, dysfunctional uterine bleeding. Now, hormonal causes. So before we discuss the hormonal causes, let's just understand that the normal hormonal cycle of a woman works like this. You have glands in the brain which are called pituitary. You have gland in the neck which is called thyroid, and we have our ovaries. So from the hypothalamus which is in the brain, some hormones are released which act on the pituitary. The pituitary again releases some hormones which act on the ovary and which act on the thyroid gland. The thyroid gland also releases some hormones. So together all the hormones form a hormonal milieu, and this hormonal milieu acts on the ovary for the ovary to produce eggs, and depending on whether the egg is fertilized or not fertilized, if it's not fertilized, which is the case most of the times in a woman's life, then the woman gets a normal period. So this is what we call as a hypothalamo-pituitary-ovarian axis. Okay. So this is the So if there is a disturbance in the HPO axis, then the hormonal milieu of the woman gets disturbed, and this can lead to various hormonal disturbances such that the target organ is unable to respond properly because we are not feeding it the right thing. In such cases, a woman may present with heavy menstrual bleeding. The most common cause of that, all of us are aware of, is thyroid troubles. So North India is relative, it comes into the goiter belt of India. So we see a lot of thyroidism. Normally, hypothyroid patients would present with milder bleeding or lesser periods, but sometimes they may present with heavy menstrual bleeding also. Apart from hypothyroidism, in which the thyroid levels, the thyroid hormone of the body becomes less, there is also a condition called hyperthyroidism, in which actually hyperactive. Such patients also often present with heavy menstrual bleeding. There are some other hormones in the body Like we have a prolactin hormone, we have some other female hormones. So if you present to your doctor with heavy menstrual bleeding, apart from an ultrasound for your anatomical workup, she's definitely going to do your hormonal workup. If something comes up in that, then hormonal diseases can normally be treated well with medications, because we can with medications correct your hormones. This could be thyroid medicines, this could be oral contraceptive pills, which are estrogen and progesterone containing, the Maladi-like pills. They could be only progesterone hormones. So depending on your condition and what you present with, your doctor is going to decide which is the best treatment for you. Right? Okay, now earlier also I had mentioned this. One more cause of heavy bleeding could be menarche. Like a girl has just attained periods, she's just started to get her periods in her adolescence, and the hypothalamo-pituitary ovarian axis, or the HPO axis, takes about 2 to 3 years to. This time there may be irregular and often heavy bleeding that girls may experience. So such a time you must definitely consult a gynecologist. She's definitely going to avoid giving hormonal pills unless absolutely indicated. But yes, the other management, like the girl shouldn't become anemic because of heavy blood loss. She shouldn't develop too much of weakness or fatigue. So all these things would be taken care of. She'll primarily be given some hemostatic drugs, hematinics or iron tablets to build her hemoglobin, some other vitamins and minerals. And I think with time, as the HPO axis sets itself, most of the times these girls normally would. Rarely we have some bleeding disorders, or women because of some medical condition be taking some blood thinners or some other medicines which make you prone to bleeding, right? So such women often present with heavy bleeding. So the treatment normally in such cases is to first stop the drug which is causing the heavy bleeding, and hormones work very well for such women, and normally the bleeding can be taken care of hormones. In patients who have had heart surgeries, so they are often on warfarin or ecosprin, and which cause them to, if the dose sometimes is not tailored properly, these women often present with heavy bleeding. But hormones normally can take very good care of them. Okay, so causes. I would also like to discuss one cause which we call as endometrial hyperplasia, or the thickening of the lining of the uterus. These patients also normally, though they would present, but sometimes such patients also present with heavy menstrual bleeding. So overall, if a woman presents to me with heavy menstrual bleeding, there are a few things I would do. First of all, I would take a very good history, what kind of periods she had earlier versus what kind of periods she's heavy have they become, what could be her likely monthly blood loss, how many children does she have, troubling symptoms, has the bleeding been so much that her general health is being compromised, what is her age, what is her reproductive status, how far away is she from menopause, does she want to preserve reproductive function or menstrual function, or she wants to do away from all this. So does she have any other comorbid conditions like a diabetes, blood pressure, a heart disease, a thyroid condition, or any other comorbid. So all these factors would come in my history. I would examine her thoroughly. First, I would do a general examination. I'll look whether she's obese, she's lean, thin, could she have other hormonal conditions. And I would definitely take a pap smear and check the size of the uterus. So if she's having the size of the uterus is normally bulky, normally we can feel the fibroids even on a vaginal check. There are polyps which are coming out of the mouth of the uterus, or they are placed on the cervix. They can be seen by most of the times during the gynecological checkup. But if they're inside the uterus, then they cannot be seen during checkup. And generally, such patients would be advised a good ultrasound. They would be advised CBC to check their hemoglobin status. They would be advised certain hormonal tests. And once you come with all these reports back to your doctor, she would be in a better situation to tell you what is giving you this heavy bleeding and what probably can be done with it. So general ways of treating heavy bleeding. First is hemostatic drugs, which normally most of you must have heard. It's called the Trapic tablet or the tranexamic acid. So many people, if they are not very far away from menopause, or if the bleeding is not too much, they normally do well with medical management. Every period they can take a few pills of this and they normally do well. Along with that, we give you hematinics or iron tablets to build your hemoglobin up. Sometimes your doctor may advise you to go in for a DNC or an endometrial biopsy to rule out any growth or any, I would say, cancer-like changes, hyperplasia or overgrowth of the endometrium. So sometimes we may ask you to go in for a diagnostic DNC, and sometimes if we do a DNC, it can also be therapeutic for the patients, because if we often such patients who are presenting with heavy bleeding begin to do well. Other way, okay, now the other form of medical management is your hormonal pills. So body has primarily two kinds of hormones. One is the estrogen and one is the progesterone. And the hormonal pills that are available are also primarily either progesterone only pills or they are estrogen progesterone containing pills, which we can safely call as contraceptive pills. So contraceptive pills are not just used for contraception. They have a lot of therapeutic purpose in gynecology. So often these pills are given to control or regulate the cycles and also to control the bleeding. So if we are externally giving you the right dose of hormones in your body for a good 21 days, then your body, your ovaries and your uterus respond just to the right dose of hormones, and normally heavy bleeding is taken care of by giving regular course of oral contraception. Pills you need to take would be decided depending on your age and your presenting condition, and one can't practically take these pills for a lifetime. So at what age you are presenting with and what is the quantum of your symptoms would decide whether you are eligible for hormonal therapy and for how long. Sometimes we put patients just on progesterone only pills because the estrogen component may have certain side effects which may be not tolerable or not acceptable for certain patients. So progesterone only pills also can work in heavy uterine bleeding. There is one more way we can administer progesterone to these patients, and I'm sure many of you must have heard of this thing called Mirena. Okay, so Mirena is an intrauterine contraceptive device, or it's like a copper T, right? Though it's not that, which is hormone loaded. So it's got progesterone hormone in the intrauterine contraceptive device, and we put it inside the uterus of the patient. It's just an OPD thing, and it's very, very simple to insert Mirena. What Mirena does is it releases a very, very small dose of progesterone hormone inside the uterus every single day. So what happens is, suppose we are giving you oral progesterones, okay? Now the progesterones first go into your stomach, then they get metabolized there, then they have to pass through the liver, and then they go into the blood, then they act onto the target organ, which is the uterus. So essentially what we are doing in this process is, obviously we are administering you a much higher dose of progesterone, plus you're also entailing certain side effects, because after all it's getting metabolized in the liver, it's going through other body organs also before it's not just acting on the target organ, which is the uterus. Other organs in the body are also facing a high progesterone, as a result of which patients may experience certain side effects, which could be nausea, bloating, constipation. For some people it may be they may be very mild, but for some people they may be intolerable. What is happening in Mirena is we are administering the progesterone directly into the uterus, and it's a very small dose needs to be released because it's directly acting onto the target organ. It's supposed to act on the uterus, and we are just it's getting released there every day. So a very small dose is released, and apart from the very small dose, it just acts there, and it doesn't go so much into your blood circulation, and your other organs are exposed to a very minuscule dose, as a result of which side effects that a patient experiences of progesterone are also hardly any. And the effect at the same time is very, very good. So Mirena, I think, has treat heavy bleeding. And Mirena has also drastically reduced rates of hysterectomy or uterus removal in women. Many women fabulously respond to this. And if your doctor thinks that it may be a good option for you, I suggest that you must opt for it. Okay, the only thing with this thing is, when we put in the Mirena, your body requires a little time to adjust to it. So I always tell my patients, give your body roughly 100 days, which is about 3 months. So on and off, you may have some spotting, you may not have some spotting. And once you give it good 3 months, and once it sets, most women would either have cyclical bleeding, which is just some spotting or just a patch every period day, or many of them even become amenorrheic. So many of them won't have any bleeding at all. So having very heavy bleeding such that it was becoming a daily problem for them, to move to having just a spot every period or even not have a period, it can have huge impacts on their lifestyle and their general health, their general well-being, their hemoglobin status, feeling of fatigue, all that can generally improve hugely, right? So I think it has really, Mirena has really changed the way we treat heavy periods in women these days. Okay. So this was in short about Mirena. And so I've covered tranexamic acid, I have covered contraceptive pills, progesterone pills, I have covered Mirena. Now again I shall come to surgical management. So if medical management, I'm sure your doctor is going to give you enough trial of medical management before deciding on surgical management, right? Because these days we have so much choice of good medical management that we first like to offer all this to our patient before we opt for surgical management. There are also certain other ways apart from like surgeries like myomectomy, polypectomy or hysterectomy. We also have thermoablations, as in we can put in a balloon inside the uterus and we put in a hot material like hot water and we raise the temperature and we cause cautery effect or burning effect on the lining of the uterus. This also has very good results and many women get cured of their problem of heavy bleeding. So these are all between your medical management and your surgical management. They are relatively non-invasive. The final mainstay of treatment, if you're not responding to any of these, if you have a surgical condition, as I said, surgical management includes cause depending on what it was. If they were huge fibroids, then either you can opt for plain fibroid removal, myomectomy, or a hysterectomy, uterus removal. If they were polyps, then they can just be removed hysteroscopically. And if there wasn't any anatomical problem and you just functionally had heavy bleeding. So many a times women have functional heavy bleeding or idiopathic heavy bleeding wherein we are not able to narrow down any cause. So this is what we call as functional menopause. Woman is having a heavy menstrual period every single cycle and we have absolutely no cause. The hormones are normal, the ultrasound is normal, the checkup is normal, everything is good, but she's bleeding so heavily. So for such patients, Mirena can be a good choice. To that, then such patients, if they fail to respond to medical management, then such patients often need surgical management. So uterus removal, as I said, can be done either laparoscopically or it can be done vaginally or it can be done as an open. All this, which would be the right surgical mode would be decided between you and your doctor. And because each mode of the way the uterus would be removed, each mode has certain pros and cons, and of course not for every type of uterus removal, right? So depending on what comorbid conditions you have, how big is the size of the uterus, whether you can be administered both types of anesthesia, whether your uterus is descending a little down or it's high up. So there are a lot of things lot of variables which come into deciding the mode of hysterectomy. So once the uterus is removed, then obviously the cause is gone and your heavy treated that way. So here I have covered most of the causes of heavy menstrual bleeding. If there are any questions, I don't see any questions right now, which is good and bad both, because that means probably I've covered everything. And yes, okay. So if any one of you has any questions, you can post it in the comment box. We shall get back to you with the answers. Otherwise, you can message me on my mobile number, which is 958247 for an appointment or any queries. And thank you so much for watching my session. If there are any questions, we shall always welcome them. Thank you, all of you.